Greetings to one and all, my PHYSIO TV viewers and friends. A very good afternoon. I am Dr. Anjali More from Sanchinti Institute, College of Physiotherapy. And today we have with us Dr. Nilima Bedekar ma'am, who is going to enlighten us on the third session of the series of lower urinary tract dysfunction. Dr. Nilima Bedekar ma'am is professor and head of the Department of Musculoskeletal Physiotherapy at Sanchinti Institute, College of Physiotherapy. She has done her bachelor's from GMC Nagpur and her post-graduation from University of UK, East London. She has also completed her PhD physiotherapy from Pune University. She is a guide, PhD guide at MUHS, and she is former member of Academic Council, chairman, POS in Allied Health, and Board of Research at MUHS Nashik. She has experience in yoga and women's health. She has also worked in this field in Muscat, Oman, and Liverpool Women's Health Hospital, UK. So over to you, ma'am.
Oh, thank you, Anjali, for your introduction. I hope you have gone into the previous sessions. So we'll revise that quickly in the middle, but we will today talk about the management of lower urinary tract dysfunction. So I would just share. Yeah. Can you view my slides?
Yes, ma'am.
I'll just shift this a little bit. So in the previous sessions, it was discussed about the clinical evaluation and the urodynamic test, which can help into the objective measurements whenever needed in special areas. Also the micturition reflexes, which guide us into the management of lower urinary tract symptoms. So today will be the session on a brief going through the assessment of the lower urinary tract symptoms and dysfunctions and overview of the physiotherapy management for the same. So what we had discussed was the importance of urodynamic testing, the test and the brief procedures for urodynamic testing, and from that, how can we do the differential diagnosis, whether it was stress or urge or mixed picture or other problems of the bladder. Also, it was important to see the micturition reflexes. So to summarize the dysfunctions and the symptoms, there is urinary stress incontinence, there is overactive bladder or urgency. Bladder compliance can be a problem where it is overdistended. There could be outlet obstruction due to various reasons, which also can hinder so many things. So it's very important to understand what is obstructing, and that needs a special investigation. Post-micturition dribble is one of it, plus incomplete voiding or residual urine, or premature interruption of the urine flow. So that also can be there due to stress or psychological problems. So it's important to do a differential diagnosis, and we had done that in the previous sessions. But this is to summarize again that what could be the factors. There could be increased abdominal pressure, the gradient not going to the urethra, or increased detrusor contraction during the filling phase, which leads to overactivity, or reduced bladder capacity in itself. That can be a big problem for having going more times, number of times, and further reducing the capacity. Compliance of the bladder is really a big challenge if there is overdistension of the bladder, which again plays with the micturition reflexes, and the bladder contractility can get affected. So that is very, very challenging area where that happens. So it's more of a health promotion related things we need to do at younger age, and we should target younger population to have a good bladder compliance. So it's equally important that bladder compliance, bladder should be stretching enough, and bladder should be stable enough, and bladder should be able to contract during the time of micturition completely to evacuate the bladder completely. So it's important to have a good compliance of bladder to have good bladder function. There are other factors which contribute to the urethral closure pressure, where the intrinsic sphincter, the abdominal pressure transmission to the urethra, the uretrovesical angle and the seal during young age that is very strong. As the age increases, this becomes weaker. So the urethral closure pressure is reduced and there can be further problems. Plus the pelvic floor musculature, if that is going to become weaker, and then the external urethral sphincter pressure generation. Also the supports. So there could be prolapsing structures which can have a problem with the outlet of the bladder, or there could be the mass or growths into this area. It's very important when women come with this problem to have a detailed history to understand the nature of the problem, because history would tell us so many things. And we really have to be very quick and efficient in checking this history, because if we ask too much in details on the first go, they might feel very stressed. So sometimes it's very easy at times if their understanding is okay. So it depends on the nature of the person. If we give a questionnaire to be filled it up and their history and things, and we review it quickly, we can then just cross-verify a few things. So that sometimes helps to, while they are sitting into the waiting area, to give this so that, and give them time to go through it. So when we get the paper in hand, we already know the details about if they had chronic obstructive pulmonary disease, or if they have constipation, if they had any neurological involvement, are they diabetic, are they on treatment, how long that is. So if we get to know this quickly, then we check on that. Plus, it's very, very important to see what are their, the social implications and the quality of life. So it's important to have the detailed history into all these areas to be able to talk about the evaluation in details and the management part. So as discussed earlier, when going into the history, after having that brief history, it's important to know about the symptoms, that during filling phase, or how many times they go, whether they have to go at night for urination or micturition, whether they have the sense of urgency. So that sensation of urgency. So we have to ask that during the storage phase, what this happens to them. During the voiding, whether they are able to completely evacuate the bladder. Is there hesitancy that it's very difficult to start the flow, or it's poor stream, or they have to strain to evacuate the bladder? If any of these difficulties are there, it's really important to get further investigations. As a matter of fact, only a physiotherapist may not be able to completely address all these issues, and we have a teamwork. So it is a urogynecologist, which is a person or urologist in terms of males, but I talk more about women. So urogynecologist, and having a good conversation with them, having the patients being evaluated by them previously will be very important for us. If directly any patient does come, because we can be first-hand practitioners and they know that, okay, this is a person specialized in women's health, I could see her. But if any of this, if we understand, we should not wait for it. The same will go with if the person says dysuria about symptoms or pain during passing urine, or there is blood in the urination or suprapubic pain. So these are the red flags. We must understand if there is a poor stream, straining, incomplete emptying, or pain while micturition or just post-micturition, and any form of hematuria. It needs further investigations. So without wasting any time, we should immediately send them for further investigations, and then come back to see them for their lower urinary expansion. So we do have in details to note about their subjective feeling about the degree of problem. On a visual analog scale, also Mantle mentions that we can have a 0 to 10 lines saying how much do you feel your life is affected due to this urinary problem and how much loss you feel you have. So all that subjective assessment also can be given. From our side, we should be able to really enable us to find out the pelvic floor muscle training, and we can have the voiding diaries and very simple measures, which without the need for invasive urodynamics. So if we can really be very patient friendly and we are able to educate the person the importance of doing the frequency and volume chart, also about the type of leakage if they can handle this. So frequency, volume, and the incontinence chart is really an important document, I must say, and they should fill it up for 3 days consecutively. If they could measure this, that can give us a very objective measurement of all the parameters, most of them, and say, done by the urodynamics, such as we can understand what is the bladder capacity. Going into the what was the maximum volume which was evacuated will tell us about the functional capacity of the bladder. How many times they put the ticks, what type of fluid they are having, and when they are having that fluid, after how much time they are going. So if they can measure that output, and if they put the leaks, if they can tick that while cough or a sneeze, like on a pressure, there was leakage, or there was a leakage before reaching the toilets, or there could be both, mixed picture. So this needs a lot of persistence, and privacy also is needed for this sometimes for the patients. So if 2 days at home and 1 day if they are working in the office environment, if they cannot measure the volume over there, but they can put the ticks for frequency, they could do that. So it is a 24 hours. So at the last night when they go, they'll put from 6 a.m. the time they wake up to the night they go. And if they have gone at night, in the morning, then they can put those ticks. So it's important to get these diaries. Now, these are not invasive. It doesn't require any money to put this volume frequency charts. We could show some examples to women that this is how we can assess, and they can themselves sometimes be very surprised that, oh, I did not know that I have so much of a problem. Or sometimes they'll say, I thought it is so severe, but it doesn't appear to be that much. So it can go either way. So we can have a great assessment by having this chart. But if they don't fill it up completely, then that can be a problem. So if they are really well versed with this, they are given enough chance to put it, this also can be a guided and taken as an outcome measure. Okay? So it will be very important. As a physiotherapist, we can get the practice done, but this is also done by the urodynamic labs, by the urologists. So 1 hour practice we have already described. There can be 24-hour or there can be functional. So this is being discussed in the first, how the practice should be done, and the utilization of practice as an objective measure of how much the leakage would be. So that the intake output chart and practice are taken as outcome measures. If we find that obstruction problem is not there, or bladder compliance of overstretch, or the person is able to evacuate completely, then if we feel that there is urinary incontinence is the only problem, pelvic floor muscle testing is very important. This was also discussed previously, but we can go through this. The subjective method of assessment is there always, but there are other measures where we can have it by EMG or pressure. So we can measure the activity on the pressure biofeedback unit or a pereniometer. And the person can herself see for how much is the contraction strength and how long can be sustained. The internal subjective evaluation is a good guide so that then we can decide whether the person is understanding the contraction, is doing the contraction and relaxation. We can check about whether there is a pain, what is the nature of the tissues, right, left, are they equal? And we can even visualize whether there are other associated muscles are contracting with it or without. Pelvic floor muscle training is important if we do find that there is urinary stress incontinence. So for stress incontinence, definitely the pelvic floor muscle testing is very important. And giving the strengthening program adds to the benefit of overcoming this problem to a great extent. For overactivity of bladder, yes, there are means how pelvic floor muscle contractions are going to work for it. So we are going to do that in brief, will be discussed. Person can do a self-assessment by once, and we as a therapist will do an internal subjective internal vaginal examination. Of course, we have to rule out if there are any contraindications of doing so immediate post-operative period, or if the person is having heavy menstrual period, or if the person is not yet sexually active. So there are various areas where we may not do an internal examination, but that's the gold standard in doing, so that we can decide what type of electrode we can use or periometer pressure. Is the person understanding this? In fact, we can give the feedback. Palpatory method can give the feedback to it. So we may also understand about the laxity into this area when we do an internal examination. So wherever possible, checking all contraindications, precautions, person's consent. This is very important step to be assessment for pelvic floor muscle testing. And if we find that the person's symptoms and the conflicting history and physical examination results are really not completely agreeable to each other, or if there is a failure of just filling up the bladder diary, not able to do the pad test appropriately, and the leakage problem is really gross and not working only with the pelvic floor muscle exercise and things, or if there is a need for any surgical investigations or surgical interventions, the urodynamic test is a must. So there are conflicting evidences on urodynamic test, and the systematic reviews and meta-analysis do suggest that it should be done if at all there is a plan for any active surgical intervention. We have gone through the details of urodynamic test and how objectively they are going to measure the problems. Okay. So the management for bladder compliance, as we know, the bladder compliance can be two ways. The bladder can be over-distended for a period of time, which makes the bladder contraction weak. So the detrusor doesn't contract strongly to completely evacuate the bladder. So that can happen, and then there can be the dribble or the urine retention. So that is an area which really needs a big attention. And if it has really becoming weaker contraction, then medications can be of help. If we find that women, especially young girls, going in school, differing, going to the washroom so long for years together, that can lead to problems. As we know that doing this for years together, definitely there can be over-distension of the bladder. It can happen during the post-operative period also, or post-delivery. So it's the midwife or nursing in charges do take care to see that the bladder is evacuated, or then they really don't allow this over-distension. So we must take care of this bladder compliance and help promotion for it. As I suggested, with the outlet obstruction, there can be other growths, or there can be prolapse of the cystourethroceal prolapsing into, and that can obstruct this outlet. So then when the person changes the position, there can be dribble, there can be residue, there can be premature interruption of urine flow. Also, if the person's psychological status is not so good, the micturition reflexes can get affected. The bladder doesn't contract completely, then contracts again. The pelvic floor muscles initially relax, then they again contract. So all that can be leading towards talking about distress and psychological involvement. That needs to be dealt with it very separately, and that needs an attention by having the relaxation strategies and reducing the stress on it. So all these are very special areas of lower urinary tract dysfunction and symptoms, and that needs to be addressed really well. Giving only pelvic floor muscle exercise for urinary incontinence is not the straight answer, because that can lead to various problems. As we know, going into the incontinence, involuntary loss of urine, which is objectively demonstrated and is a social or hygienic problem, is considered as urinary incontinence by International Continence Society. There can be functional or temporary, which is reversible. We have seen all these causes, or there could be congenital anomalies, or there are neurological problems. So that are to be really separately dealt with. So when we come to stress incontinence, so stress urinary incontinence is involuntary loss of urine on increase in intra-abdominal pressure. If a urodynamic assessment is done and it is observed and found out on the cystometry that there is a problem with the stress incontinence, then it is termed as genuine stress incontinence or urodynamic stress incontinence. If there is no urodynamic test done, then we simply put it as stress urinary incontinence. When the person says there is a leak of urine, when I cough or sneeze, I bend or lift weight, so I suddenly, there is intra-abdominal pressure rise and there is a leakage, then we will say that this is stress urinary incontinence. There's one more time where overactive bladder is there. Previously, it used to be called as urge incontinence. So we know that during the bladder storage or a filling phase, there is a detrusor contraction. And there is a spontaneous or on provocation, the detrusor does contract. And there is involuntary loss associated with strong desire to void. So this is many times idiopathic, or it could be neurological cause. There could be stress urinary incontinence and overactivity bladder. It could be a mixed picture. Giggle or orgasm are both the type, could be overactive or stress, which needs to be addressed, especially giggle in young adolescent girls, and it fades out. It can happen few times only the accident. So we may not call them as, we can only give them the reassurance and they should be fine with it. So before just proceeding to the pelvic floor muscle exercise and physiotherapy options, we must check the list of the medications if the patient is on. That's why I said the medical history and what medications taken by the patients can also affect many problems of the blood. So we need to have into the details about the medications. And if we find that any of these medications the person is on, we may reassure patient and we will still advise saying that yes, along with it, if you do these exercises, it will take a little longer, but you will be coming out of it. So have a list of the medications the person is on, and then we will talk about the management of stress incontinence. So we know what is the intake of the person. We also understand that the weight or overweight and obese women have more problem of stress urinary incontinence because there is more displacement over the period of time, the years into the pelvic floor, which weakens the pelvic floor while doing many activities. So reducing the weight to the normalization does reduce distress and incontinence to some degree. If there were habits such as smoking, or there were medical conditions such as COPD for a long time, what happens with smoking is the person has to then clear the throat, and they will do this cough many times. Every time they do this, there is a downward displacement happening. Same thing happens with chronic obstructive pulmonary diseases, that chronic cough does have an impact on the pelvic floor displacement downwards. So it's important for us to see what the person has a history of smoking or this. And we really cleverly need to talk to them regarding the smoking or regarding taking good care of the pulmonary condition, because that would lead to pelvic floor muscle displacement. Evaluation of pelvic floor muscle strength is vital because pelvic floor muscle strength has an impact directly on the pressure gradient. So assessment of pelvic floor muscle strength, there are various ways, subjective, objective. There is a perfect way of assessment. So then we will be able to guide them through the strengthening program. In the previous physio talks, there was on the pelvic floor muscle strength and activation assessment, who needs it and how to give the strengthening program. There are various ways for objective evaluation as well as giving the therapy. If the pelvic floor muscles are very weak, or to stimulate these muscles into the action, through the vaginal electrodes, we could give the pelvic floor muscle contractions. Earlier, interferential currents were in practice, thinking that they are going to really contract these deep muscles. Still, they are being used by some therapists, but we do understand that the medium frequency currents are crossing over all this pelvic area. So many physiotherapists have reduced use of interferential current therapy, and checking with the red flags and all the precautions, pelvic floor muscles can be directly be treated by giving through the vaginal electrode. Externally could be given, but it is very uncomfortable and does not reach the pelvic floor muscles deeply. So initially when it come external electrodes and handling pelvic floor, then came interferential currents, then came the vaginal electrodes. So now when the advent of vaginal electrodes is possible, we should be using that stimulation if the need be. We should also be checking about the core muscle strength, because pelvic floor muscles are the important aspect. We have to see how the person is breathing, also about the transversals and back muscles. So overall, how this whole core leading from back to front, top to bottom over this area. So we have to see the posture. We must see how the person is sitting, whether there is a stress on the pelvic floor all the time. So correct sitting posture, correct assessment is vital. So strengthening could be given, found out about what is the strength, whether only pelvic floor muscle activation is there or other muscles are really working with it. It's very important to teach the correct emptying for any lower urinary tract dysfunction. NAC is one more very important suggestion given to women with stress incontinence, such as if they feel, they know that there is going to be increasing abdominal pressure, cup or a sneeze. So a few seconds before they get to know. So the pelvic floor muscles are contracted voluntarily, and then the pressure is generated. So there is a urethral closure pressure which happens when the pelvic floor muscles do contract. So this NAC can reduce the amount of leak happening every time. So the person gets used to this NAC, and there has been demonstration that using this NAC, there is a clear reduction into the amount of leak happening with the NAC contraction. But to have this NAC correctly, the strength must be at least grade 3. If it is not that much, we have to see that the pelvic floor muscle strength really comes up with. So it's important to have this assessment, teach them correct technique, and they might require to use some pads in the meantime. It's very important for us to talk to them about what their intake, because what happens is they would like, anyone for that matter would like to reduce the intake, because they know that okay, they're going somewhere. If they reduce that intake, the production of urine will be less, and then that can reduce their problem of incontinence. If the bladder is full, increasing the pressure, there will be more leakage. If the bladder is not that full, the leakage amount will be less. So what happens? They go into this vicious cycle of reducing the water intake. Once the water intake gets reduced, the urine becomes more strong in terms of the irritants. So if this urine is having more irritants into it, then that's going to may cause the overactivity of the bladder. So that can cause an irritation to the bladder wall, and that may lead to then contractions during the storage phase. Till the time stress incontinence, during storage phase, that is not the problem. But reduction in intake, that may have a problem with the urine irritating material, and that may lead to overactivity. By this time, the bladder capacity also might get reduced because the person doesn't allow the bladder to get as much distended. So that can have a capacity reduction of the bladder, and that may lead for the person to go more and more times. So it becomes a vicious cycle when the person starts reducing the intake, going into getting irritated or getting the bladder capacity reduced, which further leads to having more and more problem with stress incontinence or frequency. Then the frequency will be increasing more and more. So we really have to see how this goes. Earlier they come to us, it is much, much better. The amount of leakage earlier is less. They could be completely become dry in about 3 months of time. So if it is very prolonged time, the muscles are very weak, it would take a lot of time. If the bladder capacity by itself has reduced, then that even needs a medical management to get the bladder stretched and other things. So we really have to think into the details for the person. So earlier, the better when they report to us. We also must see that what in general the activity the person is doing. We never forget about the functional assessment in the parts, about the personal barrier, the environmental barrier, the nature of the work the person is, the age. These factors are really important because when the person becomes sensitive towards the bladder problem, socially also they may not try to go out. So they may feel more nervous, psychologically depressed, which may lead to further problem. So overall, their activity would reduce. The whole of that quality of life is going to be impacted with any of the urinary problem. It's the basic thing which needs to be there to have a good urinary function in life. So if that gets really affected, the person becomes psychologically depressed, gets aloof, and further aggravates this problem. So overall, even the activity levels go down, further gaining weight. So it becomes a vicious cycle. So we really have to be skillfully manage the stress incontinence as early as possible, get correctly evaluated for it, check for the pelvic floor muscle strength, give them good exercise strengthening, core strengthening as well as general strengthening, correct emptying technique, a good posture, and good activity levels. Initially, they might be using the pads for their safety, that no leakage will be there. So we can also evaluate the number of pads they use daily, what type of pad, or later on they might need only a liner, panty liner. So that also talks about the outcome. So with the outcome, only pelvic floor muscle strength cannot be only appropriate outcome for stress incontinence. It will be the number of leakage per day, the amount of leakage, and the type of pads required to be used daily. So these are the more important outcome measures to be checked for stress incontinence and how much their life is affected with it. Secondarily will be the pelvic floor muscle strength, because appropriate outcome measures should be used. Though pelvic floor muscle strengthening is going to have an impact, that may not be the only outcome measure. It can be one of the outcome measures which will be used secondarily. Okay, so check about the outcome measures correctly if you're going to do any research into this area. It's very important to see all this happening so that women do become dry, they become more confident about themselves, and there can be a reversal happening. So check about what they use for their safety and not leaking. Some may have only a few drops over the panties. They may not like that much also. So we really have to do an evaluation and the management part. When it comes to overactivity of bladder or sensory motor urgency, there could be a few medications which can also help. So we need to address this simultaneously with medications and get advice of it. From physiotherapy perspective, overactive bladder takes more time to handle. And here, many changes can help to some degree. The most training technique, we call it as a bladder retraining. So having to have the bladder diary, we know that there was an urgency required, and so many times this leakage happened before the person even could make and reach to the toilet. There could be just leakage before opening the door, or entering into the cold room, or hearing running taps. So all such things, the person may have a leakage with it. So we have, and the retraining. So the number of times the person is going to go will be much more, or the person may feel that urgency. It's very, very important, and it's really good to know that this urgency and the bladder contractions can be controlled by knowing these maturation reflexes. So when the person feels that urge to go to the washroom, and she knows that, okay, just 15-20 minutes back, the bladder was inactivated, so not much urine will be left there. So few things can be started. That sitting cross-legged, so there are positions. Sitting knee over the knee, so hip adductor together, trying to do the pelvic floor muscle exercise or very strong adductors. So tightening both the adductors together, holding it for a few seconds. So doing pelvic floor muscle contractions or adductor tightening or glutei, all these muscles can have an impact on reducing the overactivity of the detrusor. Once this is done for a few seconds, the feeling of urgency can fade away and go. So this bladder retraining should be done at an home environment. The person is more relaxed and is able to do this, because accidents can still happen in the initial stage. Bladder retraining shouldn't be done at every time the person feels urgency. So to begin with, should try about 3-4 times for deferment. Should think that, okay, I've gone just 15-20 minutes back, so I am feeling this urgency. I should sit quietly, do the pelvic floor muscle activation, do the adductors, and tighten the pelvic floor strongly with the influence and overflow with other muscles. So this will, if still feels the urgency is not subsided, then try to walk as slowly, holding the pelvic floor, try to reach the toilet. So start retraining and deferment 2 times a day, then 4 times a day, and then see that going, if every hourly the person is going, then can go after each 1.5 hours. So when the deferment is done, so have to not try every time, because psychologically it is very, very challenging. Sometimes distraction also helps. So I've given advice that, okay, if you feel that urgency, just try to do pelvic floor muscle exercise and call your friend and want to gossip or chat or anything and see how it works. So psychological impact is there on this detrusor overactivity. So sometimes that urgency will go away. So the person will not feel like the bladder is contracting. The bladder does then relax into this phase. So giving appropriate retraining advice, the person has to follow this very routinely and judiciously and very religiously. But that once the person understands the importance and feels can be retrained, will work for it. So that really works very well. Positions, pelvic floor muscle exercise at that correct time does work. Electrical stimulation has been seen a very good impact on reducing the bladder overactivity. So that works very well. So we can give a few sessions in our department, and then the person can be handed over the electrical stimulator and be trained to use the stimulation. Could be having to do it once or twice a day in the position. So should be ready to use by herself. So that saves a lot of sessions coming to the department. It's mandatory to check all the contraindications when electrical stimulation we are going to use. We have to see that the colposcopy reports are there with the patient, if at all the age goes that way. There are no other contraindications being there because we are going to use the vaginal electrodes. There are suggestions that 200 to 500 microseconds and 35 to 45 hertz of frequency for some time and 5 to 10 hertz of frequency. So both the type of the fibers of the pelvic floor muscles will get stimulated by this. Vaginal electrodes do give stimulation to all the deeper structures of the pelvic floor area. So this electrical stimulation has an impact on the vixation reflexes and has an impact on the bladder contractions happening there. So detrusor to detrusor stimulating and detrusor inhibiting, all this can be really handled very well. So with this behavioral therapy, with the lifestyle changes, bladder retraining, giving good position and exercise, guiding them psychologically, and distraction can work really well. Along with it, initially medications could be taken. So that works very well with the patients. So we must see what the best possibilities we can give to the patients. Psychological stress, how to handle that. So they have to be guided for that also. We might use other therapists to help us into this, but it's a big challenge because women don't like to disclose this problem. They don't like to share their problems with many, even medical or healthcare advisors. They would confide in one or two. But if we say it will work, or as a therapist, we should have an additional knowledge and skills in order to give them the relaxation therapy, behavioral therapy. There are many therapies we can work with for such patients. So we have to have the skills of giving this psychological guidance, relaxation techniques, and behavioral therapy. So there are many options for us to handle it, because sending the person to another they may not like it to disclose everything to them. So we can work in conjunction to the gynecologist and with the physiotherapist. So we will be able to handle many problems, even the orgasmic incontinence and other incontinence types, because they would not like to disclose many things to others. Biofeedback assisted stimulation is also can be done. So they see these contractions. They do the same when they are going to use the bladder retraining program. So if there is a mixed picture, the woman does come with the problem of both the sensory motor urgency as well as the stress urinary incontinence. So we have to give the options of both, because so many times initially it could be only the stress incontinence that leading to the mixed picture or the urgent incontinence. So if we don't manage this as early, it could be both pictures, which is difficult to handle. So I would suggest we must influence even the medical fraternity, the urologists. They might not be aware that there is a trained physio around. So we should go around, we should see what are the options they are giving, because we need to have their assurance, because patients do feel that the medical doctors will be there treating them more well. Once they know us, we have more time with them, and they really then would not leave us at any time. It's important that we find different measures of giving this advice, because pelvic floor muscle exercise will be lifelong. So we need to find out really innovative ideas, how we are going to give them this training. And if they feel this is going to be whole life, nobody would like to just know this sometimes. But if we say, once you get into good habit, Matt, and all this will reduce, as you are moving, you will be doing your pelvic floor exercise and it will happen automatically to you. So don't worry. So if we give this reassurance, they would definitely like to go ahead and get better. Everybody would like to get better. But here it will be their involvement, their active involvement and participation into their health problems and how we guide them. So patient education into this area, handling them very carefully. Evaluation should be correct, the assessment, then only the management would be really helping them to have correction of the continence problem, of the dysfunctions of various things. So overall functional improvement, quality of life should be improving whenever the incontinence problem and urinary tract dysfunctions would be handled. So we should be leading to better control and, if possible, cure for them. So there are a lot of references over here. You could contact me on email or on LinkedIn. So I'll be happy to share any information out here. So I thank you very much for giving me the opportunity, Physio TV and Anjali, to have a good introduction. So if any questions from your side, one or two questions we can see, take if they have come to you.
Thank you so much, ma'am, for such an informative session. I have two questions if you're ready. So the first one would be the common urinary problems faced by elderly women.
Okay, yeah, it's a big area because sometimes they might be feeling that this is very private matter, and they might feel to just overcome by going more times or using some pads, and would not like to share even with the family, and that goes for months, years together. Now they would have mobility problem, or there could be pelvic floor muscle grossly affected. So that leads to the urinary closure pressure changes, and that leads to this stress incontinence problem. So with elderly, there are more of a stress incontinence problems rather than others. Unless they have more of a bladder infections, urinary tract infections, that may lead to overactivity of bladder. So if we understand their problem well, if infections, then that can cause to overactivity. If displacement, multiple deliveries, or being overactive immediately postnatally, not taking care during that time, that can have a problem. Plus, we know that postmenopausal, there are many challenges. The tissue dryness happens, the urethral closure pressure also gets reduced. So they have more of a stress incontinence. So I feel we should be taking this on the social media. We could go and reach these women and tell to them that if you feel that there is some such problem, you can get evaluated by your doctor whom you feel more supported, and then come to us. So they can have mobility problems and issues. So there could be medical things involved with them or connectivity issues. So going slowly to the toilet, so all those things can be there. But we can reassure them that doing simple evaluations can help them a lot, and their quality of life and their capacities would definitely improve. So we have a lot of role in women's health in elderly women, and we are more and more growing population of these women. So their problem needs to be addressed for.
Yes, ma'am. Even the self-regulatory techniques which you had discussed, the frequency volume chart, the bladder diary, which can be maintained, and they are very cost-friendly and very easily available and non-invasive techniques. So for the self,
Unfortunately, they don't fill it up correctly, and they come to us
yes,
saying, yeah, I could do only few times in a day. But then we have
correct.
to say that if this is not complete, then understanding the capacity, understanding your problem will be little more difficult. So try and make at least 2 days. So we have
Yes,
to,
ma'am.
they will get with 1 or 2 filled up and they say, no, I couldn't. So we could say that there are more methods objectively and invasive. So it's better if you try more. But in the meanwhile, we start treating them, because if only investigation and assessment is done, they won't like it.
Hmm.
So we would start the treatment. We would say that even doing pelvic floor muscle assessment sometimes is challenging, getting their consent. But once they know we are handling them with care, we show them the pelvic model. We show them the charts. These days, the 3D videos are available to show them how this
Yes.
contraction goes. So it becomes, with this situation nowadays, there are many avenues available for us to show them. So if we show them this video, which were not there when I had started practice, these videos and things were not there. We used to have a pelvis like in hand, and we used to say that this is the support, this is what is going to happen. But we have these videos to show them. And once they see this, they actually know, how to contract, how they can hold, how they can do so well. So make use of all these facilities, and they would love to see. We can show a few examples to them that, see, this is there, and these women are definitely being helped. So that will really work for them.
Yes. Yes. Correct. And ma'am, one more question for addressing the health promotion with respect to urinary problems of the later life.
Later life, I would say begin in the young age, as I said, with the school children, school girls, differing, going there. So that happens. That happens. So that should not be really a problem, because we know that deferment is not so good. So how do we handle it? So we have a health problem there. We really need to go to the schools and first see how are the toilets.
Correct.
Any public area, we find sometimes even Indian toilets are better than, I feel. And they should go if they're not okay and the crouching, because that's where, when the mixture reflexes, I said, if they crouch, then the pelvic floor doesn't relax completely and the bladder is not evacuated completely. So deferment is one, which can lead to over distension over a period of time. Second is crouching position, which will not completely evacuate the bladder. So to avoid these two things, deferment and avoid crouching. So with that seat, they should get it clean and sit on the toilet seat properly to evacuate completely. So the bladder habits, they don't drink water then because they don't want to go. So all that starts at a younger age. This can happen even during pregnancy, and then they'll feel this is natural or normal. To some degree, yes, but it doesn't get resolved postnatally, then we should check them and see whether there is a problem, or there can be delivery with, the perineal atrophy and things. So we really have to handle if there are complicated pregnancy deliveries. So we should have getting them checked if they have any such problem, because we know that all this postmenopausally they might face the symptoms. They might not face that many symptoms because their clear pressure can be stronger at that period of time. But with the growing age, all this displacement and things can happen. Okay.
Correct. Thank you so much for addressing my questions, ma'am. I'm sure a lot of doubts of the viewers also must have been cleared. I would like to extend my thanks to our chairperson, Dr. Parag Sancheti sir, our executive director, Mrs. Manisha Sangvi ma'am, our beloved principal, Dr. Apurva Shimpi sir, and also our Physio TV team and the technical support. And last but not the least, our viewers, thank you for joining us and stay tuned for more updates. Thank you, ma'am. Thank you so much.
This is an exciting opportunity for both practicing physiotherapists as well as graduating or master's level students in musculoskeletal medicine to get a comprehensive hands-on workshop. To register for the course, easiest way is to just email us at alld.pune@gmail.com. Once again, it's an exciting opportunity of hands-on course all day long, 4 days with post-test, and I hope to see you all there.